Good afternoon. My name is Megha Chokshi, and I'm a Senior Vice President at GovernmentCIO. Technology has been the glue holding together several parts in the society, especially in the last year, as it kept us connected and fueled healthcare achievements and definitely certain innovations as well. At the same time, social justice movements have rocked every industry and forced organizations to think about their impact and inclusion practices. Joining us today is Dr. Marie Bernard, who serves as the Deputy Director of the National Institute on Aging at the National Institutes of Health. As NIA's Senior Geriatrician, she is the Principal Advisor to the NIA Director. She additionally serves as the Acting NIH Chief Officer for the Scientific Workforce Diversity, or as the COSWOD. Dr. Bernard's dedication and passion in creating equity and inclusion throughout the biomedical research enterprise are profound and inspiring. Welcome, Dr. Bernard, and thank you for making time today to be with us.
Thank you very much. I'm really happy to be here, and I'm happy to say that there's been a change in my status. As of May 31st, I was announced as having been selected to be the permanent COSWOD for NIH. So I have left behind my colleagues at NIA as the Deputy Director, and I'm full-time doing the job as the Chief Officer for Scientific Workforce Diversity.
Well, congratulations. That is excellent news. And with that, my first question is going to be related to the COSWOD as well. So, your appointment now coincides with some recent commitments that NIH has made to equity, representation, diversity. And so can you go into the importance of these commitments at NIH and how they play into your role?
So at NIH, we have known for a long period of time that diversity, equity, and inclusion was important. And when you step back and you look at the studies that have evaluated the impact of diversity, it just is eminently clear that if we don't have diverse perspectives at the table when we're trying to do science, we are not going to have the maximal creativity and innovation that we need. There are lots of examples in the business world, growing examples in the scientific world, that you have papers that come out with higher impacts that are more commonly cited when you have a diverse group that's involved. You have more patents that are generated. And when you look at the population as a whole in the United States, it's getting more and more diverse among the younger segments of the population. So if we're going to maintain our momentum, taking advantage of all the talent in the country, if we're going to maintain our momentum in terms of leading and creativity and innovation, we must have diverse perspectives. So that's a lot of what's been going on at NIH.
So how has this diversity of thought helped you in the COVID world and now going forward in the post-COVID world, right? In the last year, COVID-19 has helped illuminate several disparities across gender and racial lines that we know we have to address, and they existed before the pandemic. So going into all of this and looking at all the disparities, how can we take this innovation and new thought leadership to move forward in the medical research and kind of bridge all of the disparities together?
Yes, the COVID pandemic, I'd like to think we're beyond it. I'm very concerned when you look at the rate at which the Delta variant is increasing across the country, but I really hope that all of the worst is behind us. But the COVID pandemic really demonstrated the challenges that we have with disparities in health, because we had disparate morbidity and mortality by race and ethnicity in this country. And it demonstrated to us that we needed to do a much better job at examining the causes and developing effective interventions. From the standpoint of workforce, it also demonstrated the disparities that exist for men and women, for people who come from underrepresented groups in terms of the ability to continue to conduct their research, the fact that women traditionally take on the leadership role for childcare. We did a survey. NIH did a survey of extramural researchers, people that we fund across the country to do scientific research, more than 40,000 respondents, and found that the women uniformly, particularly those who were caring for small children under the age of 5, were very stressed and very concerned about the ability to continue in their career. And people who come from underrepresented racial and ethnic groups, a similar sort of concern. So the COVID pandemic has demonstrated all those things. There is really an opportunity for us to do better as we go forward, as we're recuperating from the pandemic. One of the silver linings has been the discovery that there's a lot of the work that we do that we can do from a distance, and a lot of the interactions that we can do from a distance. And in fact, it's been found to be a great equalizer for many of our scientific meetings. We've had double, triple, quintuple the number of people attending NIH-funded meetings because they were free and people didn't have to arrange for travel or accommodations or things like that. So, there were silver linings to it, but it definitely demonstrated some of the disparities and has led to some of the new initiatives that we have at NIH.
So can you talk to some of the new initiatives? I'd heard about the Unite initiative recently that has just kicked off. So can you shed some light about that and what steps, NIH is going to be taking to diversify, much more of the biomedical research?
Yes, the NIH Unite initiative is something that was officially unveiled on February 26th at a special meeting of the advisory committee to the director. It is something that had been under development from June 2020 onward. It was spurred on by the disparate morbidity and mortality that we saw with the pandemic, and with the videotaped murder of George Floyd, just emphasizing the challenges that we have with racial equity in our country and structural racism. We had really intense leadership discussions from June through to about the end of October when we launched internally and developed the reason we call it Unite is we have 5 interacting working groups that are going after the very ambitious goal of ending structural racism. One that's looking at understanding and listening to hear from people as to what it is that we need to do. The N committee is looking at new research and health disparities and health equity research. The I committee that's looking internally at NIH to look at our policies and procedures and getting our house in order so that we can role model for the external world the sorts of behavior that we expect. The T committee that's holding us responsible for being transparent and communicating effectively internally and externally what we're doing. And the E committee that's looking at the extramural ecosystem and what sorts of changes need to be made in those areas to allow for true equity and diversity. We're really excited. It's already yielded a number of new changes at NIH. We did an update on it on June 11th at the Standard Advisory Committee to the Director meeting. We told them it's a marathon, maybe an ultra marathon, but every June and December when there's an advisory committee meeting, we will provide an update. They'll serve as our mile markers in terms of accomplishments.
Yeah, that's great. So as we talk about the role of medicine and how it has evolved over the decades also, medical research has also definitely it's better understood and how to better treat women and understand their underlying health problems. So can you share some stories that would shed light into how biomedical research and healthcare has kind of made a significant difference in improving women's health outcomes?
Absolutely. I have 3 examples that come to mind. There is a study that was supported by the National Institute on Aging, where I served as deputy until May 31st, that was called the SWAN study of women across the nation, something that, 30 years ago probably would not have been done because all of the funded NIH studies were in men. But this one was specifically to look at the menopausal transition for women. And I will tell you that as the results from the study started coming in early in my tenure as deputy at NIA, I thought, I've got to send a letter of apology to all of those women who I used to see when I was a young academic physician who were going through the menopausal transition, because all the textbooks said that the menopausal symptoms lasted only about a year or so. What we found from this study is that the menopausal transition, particularly hot flashes, last for years, depending upon your racial ethnic background. On average, 3 to 4 years for women of Asian background, on average 10 years or more for women of African American and Black background. And that's something we didn't know because we didn't study women. Another example is the profuse literature that we have now that shows that the ways in which cardiac problems get manifest are different in men and women. And we were missing that in women previously, prior to women being well included in clinical studies. And then a final example that I would bring forward would be the growing evidence, again, my past experience at the Aging Institute, that there may be differences in the way that men and women present with Alzheimer's disease in terms of symptoms, et cetera. And that suggests the possibility that there are different pathways in which the disease will manifest itself. Perhaps it'll turn out that there'll be different ways that you want to treat individuals depending on the pathway. So if you didn't have women involved, and I would say that it's a similar sort of thing when it comes to people from what's considered traditionally underrepresented groups, you miss out on understanding the full science of a phenomenon.
So that was very illuminating, especially from a personal perspective. I have seen my mother go through about 4 or 5 years of, menopausal symptoms. So it helps us understand where we are heading towards. So, this really kind of brings up another question in my mind, that when we talk about these disparities, a lot of times, people are reticent about going to, the doctors, because a lot of times it comes down to mistrust. It's about the fear in communities on what comes through the medical system. Are we going to get the correct care or not? Are we going to be looked after properly or not? And many experts have said that one way to alleviate this is to increase representation, not only in the medical community within the healthcare system, but also within the communities themselves, so that there is a better understanding and that we can explain to them what we are doing for the communities. So do you think do you think that that's really the case? What else can we do to kind of remove this lack of trust and further the understanding between healthcare and, these communities, whether it's women, whether it's communities of color? There's so many different aspects to this.
Yes. And there's such important aspects. We know that when patients are given a choice, they prefer to have a provider who looks like them, whether it's by sex or race, ethnicity. We know that providers who come from underrepresented backgrounds, again, African American, Black, Hispanic, Latino, American Indian, Alaska Natives, are more likely to practice in underserved communities where there are large numbers of those individuals. And we know that from the scientific pursuit standpoint that significant percentage of scientists, at least the scientists who apply for funds from the National Institutes of Health, who come from what are considered to be underrepresented racial ethnic backgrounds, pursue research that is health disparities, minority health, health equity type research. So all of that suggests that having those sorts of people involved in research makes a difference. And makes a difference in terms of bringing people in for clinical studies. We had a great example of how important that was with the height of the COVID pandemic. There were communities of color, communities from underrepresented groups that were really hit hard by the disease and needed to have trusted individuals to talk to about getting involved with clinical trials, getting involved with vaccine trials, and now getting involved with getting vaccinated. And we have found that working with trusted partners in the community, community groups, religious groups, academic institutions that are located there can be really impactful. But the important part of it is that you have to go in to trusted relationships and maintain those trusted relationships, not just swoop in and swoop out again. That is not a means of maintaining trust.
So I'm going to go back to something that you had mentioned a little bit earlier, the importance of data, how data can show the diversity in the different groups that we are trying to treat and we're trying to bridge. So can you talk a little bit more to that, and how, in your experience, data has really brought things to bear?
So what I can say is that, of course, we NIH are a very data-oriented organization. This position that I'm currently occupying, the Chief Officer for Scientific Workforce Diversity, or the COSWID position, was developed because of data. what was found in 2011 with a very careful analysis of data about people who applied and were successful in getting grants from NIH was that if you sorted them by race ethnicity, African Americans and Blacks, Hispanics, Latinos, Asians were at a disadvantage as compared to non-Hispanic whites. And if you controlled for all sorts of other factors, such as English as a first language, where one trained, where one was working from, and multiple other factors, that there was a persistent disadvantage for African American and Black scientists. So Francis Collins, the NIH director, turned to his advisory committee and asked for suggestions. And one of them was to develop this position, the Coswood position, to guide things. Dr. Hannah Valentine from Stanford University was the first Coswood from 2014 to the end of September 2020. I stepped in as the acting director October 1 of 2020, as I said, was selected as the permanent director very recently. And we've been able to demonstrate that over the course of time, related to a number of initiatives, probably, you can't say definitively, but associated with a number of initiatives that were started in NIH, the numbers of scientists from underrepresented groups have gone up. The success rates have gone up. They haven't, the gap isn't gone, and the numbers are still very small. We still have a lot of work to do, but that's what we are, a data-oriented organization. And when you have the data, that motivates people. In fact, as part of this NIH Unite initiative, we are working on being very transparent. We have recently posted for anyone to see the data about the people at academic institutions and research institutions that we fund in terms of their demographics, their race, ethnicity, their disability status, their sex, their career stage. We've also displayed data about our own staff, our own NIHers in terms of the same sorts of parameters. And that helps to motivate change.
So as we wrap this fireside chat up, I had one specific question, and this goes back to Unite and the T component, or the T and the E component of Unite. When NIH is taking up all of these efforts, we still know that there are barriers, lots of barriers to make sure that healthcare for women, for people of color, other minorities, it's equitable and available to all. So when you think about that, the T and the E component, what do you think about the partnerships between NIH, industry, academia, federal agencies? How can all of us kind of come together, get the transparency bit and the external component bit together to increase and improve the outcomes for everyone?
I think that it's imperative that we all work together to make advancements. Yes, NIH has a big role in funding original research, funding training in the biomedical research sphere, but we can't do it all by ourselves. And particularly, the important role of making outreach really early in the pathway of individuals thinking about becoming scientists, as early as kindergarten through to 12th grade. There is an important role for public-private partnerships to facilitate that sort of collaboration. There's an important role for thinking about mentoring programs and support for individuals as they go through high school and then college and onward. So I think we all have to work together to make this happen, and we're really open to and anxious for such collaborations across the government and beyond.
I guess this falls perfectly in line with Coswood's tagline, right? Great mind thinks differently. Is that what you said? Yes.
Great minds think differently.
So anything particular that you're very excited about in the next 1 year, especially as you look at, what's next for Coswood outside of, this collaboration piece?
I'm very excited about the opportunity to put more of a focus on the science of scientific workforce diversity. We're going to be doing regular offerings for anyone who's interested to think about things like the impact of implicit bias training that has been demonstrated in certain hands to be helpful in enhancing diversity. Looking at the science behind bringing in cohorts of scientists from underrepresented groups to become a network support for each other and changing cultures at institutions. I'm really excited about the opportunity for us to step back and look comprehensively at all of the literature on the benefits of scientific workforce diversity to see what the gaps and opportunities are for further investigation.
That's great. Thank you, Dr. Bernard. I thoroughly enjoyed hearing your insightful inputs, commentary. I am looking forward to discussing this further with you and really wishing Coswood, your role as Coswood, a great success. I'm sure there's more to come, and I'm looking forward to hearing some exciting news from your office. I would now like to hand over the next fireside chat, The Future of AI is Female, to my colleague, Kate. Thank you again, Dr. Bernard.
Thank you.